So of course I had to pick the Singapore Sling when I was offered these choices. So this is a picture from actually a Singapore Sling from Raffles Bar. They serve about anywhere between 800 to 1,200 Singapore Slings a day. But if you want a cheap version, fly on Singapore Airlines and they'll give you the same thing as well. If you sit in business class, they'll give you as many as you want, free of charge as well. So you can save a bit of money. But anyway, okay. So this is my case, 68-year-old Chinese lady, IT consultant. She's a driver. She's a diabetic, but pretty well controlled. Mild non-proliferative diabetic retinopathy, no systemic edema, bilateral cataracts, physiological cupping. You can see a refractive power on both sides, slightly hyperopic with a bit of astigmatism on the left eye. And visual acuity reduced down 612, 615. She wishes to be spectacle free, independent. Of course, as an IT consultant, she really focuses a lot on reading at computer range as well. So my surgical plan was basically to do the left eye first, so obviously the worst eye with the worst vision. And often with the Teleon range, I do like to do a mix and match with the FEMTIS. So I start off with an MF15 lens, which is the EDOF version, because often they still get very good near visual acuity result. So as with every patient with a premium IOL, it's important to look at the tomography and the wavefront aberrations. You'll see slightly higher posterior elevation there at the back, about 1.74 in the right eye. But I mean, the Teleon lenses do very well, or the FEMTIS does very well, even in this kind of situation, even though bear in mind this patient is a driver as well. Left eye looks all pretty much basically normal as well. So left eye surgery was routine. Unaided distance visual acuity was 20/20 unaided with an N5 intermediate and also N5 for near, which is fantastic outcome. Of course, I see this in about 70% of my patients that have undergone lens with the MF15. So for the right eye, so we went for the right eye. So this is basically what happened. So she had the rexus created with the femtosecond laser. And during the IA, or when the lens basically came out, I noticed there was a slight tear in the posterior capsule. As you can see when I'm doing the eye a bit more carefully over here, so I carefully removed the rest of the cortical remnants. And you can see just in this last area over here, there's a small PCR in the peripheral area over here. So I'm irrigating, I'm putting some viscoelastic over here to expand the capsule, push the vitreous back. There you can see the PCR on that side over there. But you know, a nice intact anterior capsule, you can see has been created on the visual axis by the Z8 femtosecond laser. So I took out the remaining part of the cortical material. And then, of course, now I've already promised this lady, you know, she's going to have a multifocal lens in this eye. And of course, there's going to be a rexus fixated lens, but now we have a posterior capsule in the posterior, in the posterior break in the posterior capsule. So a bit of an anterior vitrectomy in this area. I wasn't really sure that there was actually any vitreous there, to be frank, but I thought it'd just basically be on the safer side. And now we're going to basically put the lens in. So now I use the FEMTIS lens. This is an MF30 lens, so it's give you slightly better near vision. I implant it over a second instrument, so I don't want it to go inside the capsule. Now remember, when you put this lens in, I'm going to clip the capsule to the anterior capsule. And normally we clip this from the bag and elevate the flanges. But this way, what I did is I did it the opposite way around. So what I do is just gently tuck the haptics into the capsular bag. And of course, then the anterior flange is automatically clipped into the capsule. And that's the easy side, because that's the side where it hasn't gone in. This side, a bit more closer to the wound, is a little bit more tricky, because you need to try to grab the haptic to basically fold it into the capsule as well. So this is where you need to use the Singapore Sling. So you'll see it in a minute. And what I will basically do is, as I elevate the lens up, I will sling it. So that's the sling over here with a Sinski hook. So that's the sling holding the flange. And then that will give me better access to the haptic, which then basically will go into the capsular bag. So you can see it folded down. So this is now into the capsular bag. And then the flange will clip into the anterior capsule as we do normally when we basically use this lens. Okay, so now it's the two big flanges, and then the two small flanges can gently clip into the capsule, and you have a lens perfectly secured on the anterior capsule itself. This is what the patient basically looks like, basically a day post-op. So you can see the left eye where you got that PC tear, and on the right side, obviously, there was uncomplicated, but this is the valuable thing. If you look at the visual acuity outcomes on the left eye at day 1, pretty good. 1 week, excellent. 1 month, 3 months, very good. And the right eye that had the PCR, almost exactly the same visual acuity outcomes, achieving the same outcome, almost same outcome at 1 week, and the same outcome at basically at 3 months, even though you got a posterior capsular break. And then when you do basically a UBM, you can see that the lens is nicely lying in position on the anterior capsule and the haptics in the back. And that's your Singapore Sling. Thank you.
with the FEMTIS technology, we fixate the lens on the capsular rhexis, not inside the posterior chamber bag. Actually, this is an ideal technology to use in these kind of situations. So I think in any case where there's a possible compromise in the posterior capsule, such as in patients where you have maybe posterior polar cataract, where there may well be posterior capsular compromise, you don't really know, to be frank, until you're doing the surgery. I think that basically vexillary lens is a fantastic choice, but really more importantly, especially in those patients that want to get a premium IOL outcome, where they want better uncorrected not only distance vision but also intermediate and near vision as well. I think it's much safer clipping it to the capsule than putting it into the capsular bag, because you always worry about in the long term when you put the lens in the bag how stable it's going to be as well. And especially in those cases that may have preoperative astigmatism, where you don't need to worry then if there is a tear, how it's going to affect the axis of the lens itself when it's lying in the capsular bag. So there is no negative dysphotopsia, and again, this really comes down back to the FEMTIS technology of where the lens position is, because it's a bit more anterior. Of course, it negates that, and I use this lens as first choice in many patients who had experienced negative dysphotopsia in their first eye cataract surgery that then come to see me for implantation. And this can be quite severely visually debilitating, especially for people who are quite active in their job where they need good eyesight. For example, pilots, for example, where they merely do notice that arc effect from there as well.